Hi everyone, my name is Jackie Berknes-Gartman. I'm a GI and liver pathologist at Johns Hopkins, and today I'm going to be discussing pathology of appendiceal neoplasms. I'll start by going over the criteria for low-grade appendiceal mucinous neoplasm or lamin, high-grade appendiceal mucinous neoplasm or Hammond, and mucinous adenocarcinoma of the appendix. I'll then discuss several mimics of appendiceal mucinous neoplasms and how to distinguish these, as well as how to classify appendiceal mucinous neoplasms that have metastasized to the peritoneum. Finally, I'll briefly discuss goblet cell adenocarcinoma and how to recognize low and high-grade histologic patterns. So let's get started on our first topic, which is classification of appendiceal mucinous neoplasms, and I'm going to be structuring this around the WHO 6th edition classification of tumors. For learning purposes, I find it useful to look at an algorithm when we're discussing appendiceal mucinous neoplasms, and this walks us through how we first assess these neoplasms at low magnification and then move to higher magnification. So the first thing I'm going to look for is the pattern of invasion. There's three possibilities. The first is that a tumor can be confined to the muscularis mucosae, which will give a differential of either mucinous adenoma or other mimics. Then if I see a pushing border of invasion, which is characterized by a very flat front of the tumor that is pushing downward into the underlying layers of the appendix, that's going to put me into a category of either a low or high grade appendiceal mucinous neoplasm, lamin or Hammond, depending upon the cytology. And finally, if I see infiltrative invasion, I'm going to be at a diagnosis of mucinous adenocarcinoma with or without sigma ring cells. So we're going to walk through each of the components on this algorithm, labeling mimics for later in the talk. So let's go ahead and get started with mucinous adenoma. Mucinous adenoma was not used in the 5th edition of the WHO classification, but has been reintroduced in the 6th edition. This is defined as a mucinous neoplasm that's confined to the muscularis mucosae. It can have low or high grade dysplasia, but the important thing is that since this is confined to the mucosa, it does not progress. And that's essentially the reason that this category has been added back into the WHO, is to designate that these are not going to further progress and do not require treatment aside from an appendectomy. This is an example of an appendiceal mucinous adenoma, which is actually a screenshot from one of the whole slide images in the WHO classification of tumors. So we can see that our epithelium has low-grade dysplasia. It has dark, elongated, crowded nuclei, similar to what you'd see in an adenoma, but we have abundant mucin and a villiform configuration. The thing that would distinguish this from lamin, which we're going to talk about next, is that we still have retained muscularis mucosae underneath of all of these glands, as well as retained lamina propria. So as we mentioned, we can diagnose this as an appendiceal mucinous adenoma, and we expect that this is not going to progress, and this patient can be cured by appendectomy. Now let's move on to our next category, which is lamin or low-grade appendiceal mucinous neoplasm. As the name implies, low-grade appendiceal mucinous neoplasm is characterized by low-grade mucinous epithelium, which can have variable architecture ranging from flat to undulating to papillary. The main histologic feature that we want to recognize is a pushing pattern of invasion, which is characterized by loss of the lamina propria and muscularis mucosae, typically with underlying fibrosis. In cases of lamin or suspected lamin, we want to submit the entire appendix for histologic examination, both to get the correct diagnosis and for staging purposes. If a lamin is confined to the muscularis propria, then resection with negative margins is curative. However, if the appendiceal surface is involved, disseminated disease can occur, and in that setting it's very important to mention whether there's acellular mucin versus cellular mucin on the serosal surface. With only acellular mucin on the serosal surface, assuming it has not disseminated elsewhere, we have a 3 to 4% risk of recurrent disease, meaning pseudomyxoma, whereas we have a 33 to 36% risk with cellular mucin. Here we can see a nice example of a low-grade appendiceal mucinous neoplasm where we have cells with low-grade cytologic atypia, meaning dark, elongated, crowded nuclei, and abundant apical mucin. And I see that I have a complete loss of my normal lamina propria and muscularis mucosae, and instead I have this undulating border and some underlying fibrosis. Here we can see another example of lamin at higher magnification, and this really nicely shows both the cytology and the underlying pushing border and fibrosis. So similar to the last case, we have dark, elongated, crowded nuclei characteristic of low-grade dysplasia, and we have apical mucin. And underneath of this, we can see that there's a hyalinized submucosa, as opposed to having lamina propria and muscularis mucosae underlying it. And here's one more example. This one has more of a papillary architecture, but again, we can appreciate the low-grade cytologic atypia and the underlying fibrosis with lack of a lamina propria and muscularis mucosae. In terms of staging, Lamin is somewhat unique in that we essentially skip T1 and T2. So lamins that are confined to the submucosa or muscularis propria are staged as in situ lesions, and this is because they can be cured by appendectomy. We then skip T1 and T2. T3 is when the either epithelium or mucin from the lamin is going into the subserosa or mesoappendix, and T4 is characterized by extension to the serosal surface for T4A, or extension into surrounding structures for T4B. So we're coming back to our first example of lamin that I showed, and this could be staged as an in situ lesion because it's confined to the submucosa. In contrast, this would be staged as PT4A because we have mucin that's going out to the serosal surface. And one thing we want to check at higher magnification is making sure that this is truly something that was present in situ rather than mucin that just escaped during the grossing process, because as you would imagine, when we're grossing these specimens, it's not uncommon for mucin to spill out of them. But I can tell that this is mucin that's truly perforating out of the appendix going to the serosal surface because I have an associated fibrotic response in here. In contrast, this is an example of displaced mucin from grossing. So on the left side, we can see this lamin at very low magnification. We can appreciate our pushing border. There's some fibrosis of the underlying submucosa. And then we have at the very bottom of the image some mucin that is sitting on the serosal surface. But when we go to higher magnification on the right-hand side, we can see that there's a bit of a gap between the serosal surface and the mucin, and we don't see any fibrotic reaction or inflammatory reaction to the mucin. And this helps us to recognize that this is just displaced mucin and should not be called a T4A. Moving on to our next diagnosis, Hammond has essentially the same architecture as lamin in that it has a pushing border with loss of the lamina propria and muscularis mucosae and underlying fibrosis, but it now has high-grade cytology. And some advocate for using at least 10% high-grade cytology to make this diagnosis to make sure that we're not calling this on a very small area. So as I mentioned, this is characterized by pushing invasion, and we can look for high-grade cytologic and or architectural features. So some of the cytologic features we can look for are nuclear enlargement, hyperchromasia, pleomorphism, atypical mitotic figures, loss of polarity, meaning that the cells are at different locations in the cell rather than all sitting at the bottom of the cell. And then in terms of architecture, we can look for cribriform or micropapillary architecture. The appendix should be submitted entirely for histologic examination to make sure that there's nothing worse, such as an adenocarcinoma, and also to appropriately stage these. Due to the rarity of Hammond, there's limited information on prognosis. However, Hammond confined to the appendix in studies that have been done so far seems to behave similarly to lamin. However, disseminated disease is more likely to be high grade. This is a nice example of a Hammond where we can again see the pushing border that can be seen in either lamin or a Hammond, where we have loss of lamina propria and muscularis mucosae and underlying fibrosis. However, now instead of having our elongated nuclei lined up next to each other like pencils as you would in an adenoma, we now have significant pleomorphism, loss of polarity when we look at our nuclei here. And here we can see two other areas at higher magnification. On the left, we can appreciate significant nuclear pleomorphism and loss of polarity. And on the right, we can start to see some micropapillary architecture. Hammond is staged the same as adenocarcinoma, so we don't use the lamin staging system. So we're going to be using criteria for T1 through T4B, similar to what we would use in the colon. In contrast to Lammen and Hammond, mucinous adenocarcinoma is characterized by infiltrative invasion, and it can be graded as grade 2 or 3 based upon the presence or absence of signet ring cells. Mucinous adenocarcinoma grade 2 will typically have high-grade cytologic features similar to those that I described for Hammond, and it's defined by an invasive growth pattern. This can either take the form of angulated glands with desmoplastic stroma, similar to what you'd see elsewhere in the colon, or it can have this pattern that some call a small cellular mucin pool pattern, where you have small pools of mucin containing neoplastic epithelium. Mucinous adenocarcinoma tends to behave aggressively and often has peritoneal involvement at presentation, and this is typically treated with a right hemicolectomy and otherwise is treated similarly to colorectal adenocarcinoma. We'll talk more specifically about management of disease that has disseminated to the peritoneum later. This is an example of mucinous adenocarcinoma of the appendix. So we can see that this neoplasm consists of at least 50% mucin, which is required for a diagnosis of mucinous adenocarcinoma as opposed to conventional adenocarcinoma. And we can see some larger glands, but we also have foci of smaller glands that have an angulated appearance and fibrotic stroma. Here we can see some more examples of mucinous adenocarcinoma at higher magnification. On the left side, we can see angulated glands with desmoplastic stroma, and on the right, we can see an example of neoplastic epithelium floating in mucin, and we can really nicely appreciate those high-grade cytologic features. Finally, we have mucinous adenocarcinoma with signet ring cells, grade 3. Signet ring cells can be found floating in pools of mucin or infiltrating the appendiceal wall, or both. They may comprise the entire tumor, or there may be an associated glandular component. If the signet ring cells comprise at least 50% of the tumor, then the correct diagnostic term is mucinous signet ring cell adenocarcinoma. And in these settings, we want to rule out goblet cell adenocarcinoma. As we'll talk about later, high-grade pattern of goblet cell adenocarcinoma can have signet ring cell morphology. Peritoneal disease is common at presentation with this aggressive neoplasm, and treatment is similar to colorectal carcinoma, again with the caveat that we may be looking at some additional treatments for disseminated peritoneal disease. Here we can see two examples of mucinous adenocarcinoma with signet ring cells. On the left side, we can see that we have signet ring cells that are floating in a pool of mucin. We also have some other poorly differentiated glandular cells, which are not forming signet ring cells. And then on the right-hand side, we can see our signet ring cells at higher magnification. Again, here they're floating in a pool of mucin, and we can see the characteristic large mucin vacuole and nucleus that's displaced to the periphery. Now that we've discussed the classification of primary mucinous neoplasms of the appendix, let's talk about a couple of histologic mimics. So going back to our algorithm, we walked through everything except for the mimics, and these are essentially going to be confined to the lamina propria and muscularis mucosae for the most part. There is going to be at least one exception to this. Mucocele or retention cysts results from obstruction of the appendiceal lumen, and it's characterized by a distended mucin-filled appendiceal lumen. The normal epithelium may be attenuated or lost, either in areas or completely, and there can be associated foamy histiocytes, chronic inflammation, or calcifications. This can be distinguished from Lammen because it can have residual areas of normal mucosa with lamina propria, and the underlying architecture of the appendiceal wall is maintained. But in these settings, we do want to submit the entire appendix to make sure we're not missing a Lammen that's become partially denuded. So here we can see an example of a mucocele or retention cyst at very low magnification. We can appreciate that the appendix is distended and filled by mucin in the lumen, and at the bottom we can appreciate some residual mucosa. At higher magnification, we can see that the mucosa still has some crypts. They appear injured, but they do not appear dysplastic, and we have preserved lamina propria and muscularis mucosae, telling us that this is definitely not a Lammen. Appendiceal diverticula are another important potential mimic to recognize, and these are characterized by herniation of the appendiceal mucosa through the muscularis propria, which can mimic the pushing border of a Lammen. We can also end up with extra-appendiceal mucin in the setting of a ruptured diverticulum. These can be distinguished from Lammen again by areas of intact crypt architecture and lamina propria and associated inflammation and reactive changes, but again we want to submit the entire appendix to exclude a Lammen. Here we can see an example of a diverticulum. So on the left side of the slide, we can see the background normal appendix, and then on the right-hand side, we can see an area where the mucosa is herniating outward through the submucosa and muscularis propria into the surrounding mesoappendix in this case. There's likely some associated mucin in the lumen there. It's a little hard to see at low magnification. And I can see that I'm losing some of my my normal mucosa in that area, but given that the background mucosa all looks pretty normal away from the diverticulum, I'm comfortable saying that this is not a pushing border of a lamin and is rather just a benign diverticulum. And again, of course, we'd want to submit the whole appendix to make sure that we don't see anything concerning. Post-inflammatory mucosal hyperplasia is another potential mimic of lamin, which can be seen in the setting of appendicitis or diverticula. Histologically, you're going to see increased goblet cells with interspersed non-mucinous columnar cells, and it can have a hyperplastic or serrated appearance, more pronounced near the surface rather than the bases of the crypts. This can be distinguished from lamin because it has intact crypts and lamina propria, preserved architecture of the appendiceal wall, and often some associated inflammation, particularly if this is in the setting of appendicitis. This is an example of post-inflammatory mucosal hyperplasia in the appendix, and it looks like we have both an associated appendicitis and a diverticulum. So at the top of the slide, we can appreciate some a more purple area, which likely represents some acute inflammation in the setting of acute appendicitis. And in the lower left, we can appreciate an area where the mucosa is herniating outward and forming a diverticulum. At higher magnification, we can nicely appreciate the post-inflammatory mucosal hyperplasia that I described previously, where we have this irregularly shaped lumens or serrated architecture that's more pronounced at the surface, not really extending to the bases. So in this context, we would call this post-inflammatory mucosal hyperplasia. Again, we have preserved lamina propria and muscularis mucosae, so this is definitely not a lamin. We can also get polypoid lesions of the appendix that are similar to those that occur in the background colon, and these can include hyperplastic polyp, sessile serrated adenoma or lesion, tubular-villus, and villus adenomas. Similar to the other mimics we talked about, these have preserved lamina propria and muscularis mucosae and lack pushing invasion. In the absence of dysplasia, there's no risk of progression. Lesions with dysplasia can develop invasive adenocarcinoma. This is an example of a hyperplastic polyp involving the appendix, and these tend to involve the appendix focally rather than diffusely. At higher magnification, we can appreciate the typical histologic features of a hyperplastic polyp with serrated or star-shaped lumens that are more pronounced at the surface than at the base. And the way we would distinguish this from post-inflammatory mucosal hyperplasia is simply that this is not in the setting of inflammation and it's a localized lesion. This is an example of a sessile serrated adenoma or lesion, adenoma being the older term and lesion being the new term used by the WHO. And this is seen circumferentially involving the appendix. At higher magnification, we can appreciate the serrated lumen as well as a crypt in the middle of the image here that is dilated, and that's the characteristic feature of a sessile serrated adenoma or lesion. Sporadic tubular adenomas can also occasionally occur in the appendix. So here we have an example of a tubular adenoma. It's forming a localized lesion with your typical low-grade dysplasia, and this has preserved lamina propria and muscularis mucosae. Endometriosis with intestinal metaplasia is the last potential mimic of lamin that I'm going to discuss today. When intestinal metaplasia occurs in endometriosis, it can mimic a lamin because it develops both a histologic appearance of intestinal type epithelium as well as immunohistochemistry labeling for intestinal markers. However, if you see associated endometrial type stroma, that can be a helpful clue to the correct diagnosis. In terms of immunohistochemistry, endometrial glands that lack intestinal metaplasia are typically going to be positive for CK7 and ER. However, when they develop intestinal metaplasia, they will instead express CK20 and CDX2, which are typical markers of colonic or appendiceal epithelium. The endometrial stroma will continue to label for ER and CD10 regardless of what's happening with the glands themselves, so these can be really helpful markers. This is an example of endometriosis with intestinal metaplasia, and you can see how this could easily mimic a lamin because we have an area that looks like it may have a pushing border and is lined by intestinal type epithelium with abundant mucin. However, I do see some associated hemorrhage as well as a little bit of spindly type stroma in the upper left, which gives me the clue to the correct diagnosis. And here I can see a CD10 immunostain, which is labeling the endometrial type stroma, so this allows me to diagnose this as endometriosis with intestinal metaplasia rather than as a lamin. The last topic that I'd like to discuss in this section is peritoneal metastasis of appendiceal mucinous neoplasms. One thing that makes classification of appendiceal mucinous neoplasms in the peritoneum challenging is that the terminology for these has evolved over time. The Peritoneal Surface Oncology Group International, or PSOGI, developed a three-tiered classification for disseminated peritoneal disease. Low-grade neoplasms were called either low-grade mucinous carcinoma peritonei or disseminated peritoneal adenomucinosis, whereas high-grade lesions were called high-grade mucinous carcinoma peritonei or peritoneal mucinous carcinomatosis with or without Segner ring cells. The current WHO 6th edition includes a three-tiered grading system for peritoneal metastases using the terms mucinous carcinoma peritonei grades 1 through 3. Here we can see an algorithm for classification of appendiceal mucinous neoplasms involving the peritoneum, similar to what we used for localized appendiceal neoplasms. The first thing we assess in this particular algorithm is whether or not epithelium is present. If epithelium is absent, we will render a diagnosis of acellular mucin. If neoplastic epithelium is present, then we need to distinguish between low and high grade disease. So we're going to start out by talking about acellular mucin. While I typically use the term acellular mucin, some pathologists prefer to use the term mucin devoid of neoplastic epithelium because you can have inflammatory cells such as foamy histiocytes, as well as mesothelial cells. As I mentioned, foamy macrophages may be present in the mucinous deposits, and these should not be misinterpreted as signet ring cells. So if you're not entirely sure on the H&E, you can always try a keratin and a CD68, as the keratin would label epithelial cells and the CD68 would label histiocytes. Adequate sampling is important because this is going to behave more aggressively if it's cellular mucin as opposed to acellular mucin. In terms of treatment, this is typically treated with cytoreductive surgery, as well as hyperthermic intraperitoneal chemotherapy, which is referred to as HIPEC, and this has a low risk of recurrence if it is truly acellular. Here are some examples of acellular mucin. On the left side, we can see these pools of mucin within fibrous stroma, which happens to be adherent to the diaphragm because you can see skeletal muscle on the edge of the photo. And at higher magnification, we can appreciate that there may be a couple of inflammatory cells in there, maybe some fibroblasts, but we don't see any neoplastic epithelium. When we detect neoplastic epithelium within mucinous deposits, we need to assess two main features to determine whether we're dealing with low versus high-grade disease. In low-grade disease, we're going to see a pushing border and low-grade cytology, whereas with high-grade disease, we expect to see infiltrative invasion and high-grade cytology. So let's get started with our low-grade neoplasms, which are called mucinous carcinoma peritonei, grade 1. Historically, there has been some controversy as to whether this entity should be called a neoplasm or carcinoma. The argument for calling it a neoplasm is that the terminology lines up with the terminology used in the appendix. So for instance, a low-grade appendiceal mucinous neoplasm in the appendix would then have a low-grade mucinous neoplasm in the peritoneum. However, this does behave aggressively, so there is therefore an argument that biologically this is a carcinoma. Going forward, I'm going to be using the WHO 6th edition terminology, which is mucinous carcinoma peritonei along with a grade. So for grade 1 disease, we're going to look for low cellularity at low magnification. Typically, it's going to be less than 20% of the tumor consisting of cells at 20x. That just gives you a general ballpark, but isn't your main thing to make the diagnosis. But then we need to specifically look for a pushing border and low-grade cytology, and we need both of those things in order to say that something is low-grade. Almost all of these arise from primary lamin. Intra-abdominal recurrence is common, but lymph node involvement is rare. And the main reason that it's important to distinguish between this low-grade disease and high-grade disease is that systemic chemotherapy is not effective for low-grade tumors, so these patients are primarily treated with cytoreductive surgery and heated intraperitoneal chemotherapy, or HIPEC. Here we can see an example of mucinous carcinoma peritonei grade 1, and at very low magnification we can appreciate that this has fairly low cellularity, with the tumor cells themselves comprising a low percentage of the overall tumor, and a lot of this consisting of just mucin and some associated fibrosis. We can also see how this has a pushing border. So although I have several areas of neoplastic epithelium and they're not all connected to each other, I can easily draw lines around each of these areas, and I'm not seeing smaller, more infiltrative appearing glands. I am seeing some fibrosis, but I wouldn't consider this true desmoplasia. At higher magnification, we can again appreciate that nice smooth pushing border, and we can now start to appreciate the low-grade cytologic features consisting of dark elongated crowded nuclei that are lining up next to each other like pencils, similar to that seen in a tubular adenoma, and we have apical mucin. And here we have an even higher magnification picture, again demonstrating those dark elongated crowded nuclei that are all lined up next to each other, and the apical mucin. Going back to our algorithm, when we have infiltrative invasion, which is typically associated with high-grade cytology, we're then going to be at either a diagnosis of mucinous carcinoma peritonei grade 2 or grade 3, depending upon the presence or absence of signet ring cells. Mucinous carcinoma peritonei grade 2 is characterized by high cellularity at low magnification, with the neoplastic cells typically comprising over 20% of the tumor volume. Infiltrative invasion, either your typical angulated glands and desmoplastic stroma or the small cellular mucin pool pattern that we talked about earlier, and typically high-grade cytologic features. Lymph node involvement can occur with grade 2 disease, and these patients therefore are typically treated with systemic chemotherapy, and they may or may not also receive cytoreductive surgery and HIPEC depending upon their response. Here we have an example of mucinous carcinoma peritonei grade 2, and compared to the grade 1 disease we saw before, we can appreciate much higher cellularity, and here we can see more infiltrated pattern of invasion, where instead of those very large glands with a smooth border, we have numerous smaller glands, some of which seem to have some associated fibrotic stroma around them, some of which are floating in mucin. And these also have high-grade cytologic features, meaning that I'm starting to see pleomorphism, and the cells are losing polarity within each of the glands and are no longer lined up next to each other like pencils. Here's another example at higher magnification of these small glands in mucin pools. One at the bottom looks like it has a bit more fibrotic stroma around it, and this again has high-grade cytologic features with pleomorphism and with loss of polarity of the nuclei. Going back to our algorithm, the next thing we assess for is signet ring cells, and if these are present in a sufficient quantity, we can then make a diagnosis of mucinous carcinoma peritonei grade 3. This, as I mentioned, is defined by signet ring cells, and these can be either floating in mucin or infiltrating the tissue, or both. And this diagnosis should only be made if there's a significant signet ring cell component. So we don't want to see a few degenerating cells that may look a little bit like signet ring cells, and it's been described in the literature that having at least 10% signet ring cells is more reproducible. Interestingly, this pattern can also be seen with metastases from goblet cell adenocarcinoma, so we do want to figure out what the primary tumor was. And as in other types of cancers, signet ring cells confer a worse prognosis. Lymph node involvement is more common than if signet ring cells are absent, and these patients receive systemic chemotherapy plus or minus cytoreductive surgery and HIPEC. Here's an example of mucinous adenocarcinoma with signet ring cells grade 3, and we can see that a portion of this tumor consists of signet ring cells where we have a large central mucin vacuole and the nucleus pushed off to the side, and we also have a little bit of glandular formation as well as some clusters of cells that do not have signet ring morphology. This, in contrast, is a diagnostic pitfall of occasional detached degenerating cells in the setting of otherwise low-grade disease. So we do want to, if we're going to call signet ring cells, make sure that there's a significant component and that it's not just in an area where the tissue is degenerating. Occasionally we encounter a situation where the histologic grade is different between the primary and peritoneal disease. In this setting, the overall grade should typically be based upon the peritoneal disease, as this is the most likely to affect patient prognosis. And of course, we want to ensure adequate sampling both in the main tumor and in any peritoneal metastases. Staging of metastatic disease takes into account both whether the mucin is cellular versus acellular and its site. M1A is defined as intraperitoneal acellular mucin, so it's not going to have any identifiable tumor cells. M1B is intraperitoneal metastasis only, now with neoplastic tumor cells, and M1C is fairly uncommon but does occur, and it is metastasis to sites other than the peritoneum. For instance, I have occasionally seen this in the pleural cavity. And now for the last section of this talk, I'd like to very briefly discuss goblet cell adenocarcinoma. The term goblet cell adenocarcinoma combines previous categories of goblet cell carcinoid and adenocarcinoma X goblet cell carcinoid. Essentially, this is an amphicrine-like tumor, so it's going to show features of adenocarcinoma and of a neuroendocrine neoplasm. And this was previously considered primarily a type of neuroendocrine neoplasm, but now is thought to be more biologically similar to an adenocarcinoma as it can behave aggressively. Histologically, by definition, this needs to have tubules or clusters with goblet cell morphology, at least focally. And this often shows focal labeling for neuroendocrine markers, but I never actually do the neuroendocrine markers in this setting because they're not really sensitive or specific. Low-grade tumors are typically lower stage, whereas higher-grade tumors are typically higher stage and more frequently metastasize. And treatment varies but can consist of additional surgery, chemotherapy, and or cytoreductive surgery and HIPEC. Goblet cell adenocarcinoma has unique criteria for grading, which depends upon the percentage of low versus high-grade histologic patterns. The low-grade pattern consists of tubules or clusters with goblet cell morphology. There may be a limited amount of tubule fusion or trabecular growth if these are cut tangentially, and there may be associated acellular mucin. In contrast, the high-grade pattern can take several different forms. There can be fusion of goblet cell clusters and tubules with complex architecture, large aggregates of goblet cells floating in mucin, a sheet-like growth pattern, single infiltrating cells which may have a signet ring cell-like morphology, and conventional adenocarcinoma. There can also be an undifferentiated appearance. Here is a very low magnification picture of a goblet cell adenocarcinoma. And at this magnification, we can appreciate that there are tubules that are diffusely infiltrating the wall of the appendix. At higher magnification, we can appreciate the low-grade histologic pattern consisting of these nests or tubules that are lined by goblet cells. So since this comprised the whole neoplasm in this case, this was considered goblet cell adenocarcinoma grade 1. Here we have another example of goblet cell adenocarcinoma. This time it looks like we're looking at a bisected appendiceal tip rather than a cross section, but we can again see these little nests infiltrating the wall of the appendix. And at higher magnification, this had a couple of different patterns. So we have our typical low-grade pattern on the left, which comprised about 60% of the tumor. But then we have these single infiltrating cells, which resemble signet ring cells that comprised about 40% of the tumor. So based upon the criteria, this was called goblet cell adenocarcinoma grade 2. Goblet cell adenocarcinomas are staged similarly to conventional adenocarcinomas due to their aggressive behavior. And as I mentioned before, higher grade tumors typically present at a higher stage. So now that we're drawing to the end of this talk, I'd like to go over a few take-home points. A systematic algorithmic approach can be helpful for diagnosing appendiceal mucinous neoplasms. Both within and outside of the appendix, low-grade disease is defined by low-grade cytologic features and a pushing border, whereas high-grade disease is defined by high-grade cytologic features and an invasive growth pattern. Mimics of lamin can often be differentiated by their preserved lamina propria and lack of a pushing border. And goblet cell adenocarcinoma is graded based upon percentages of low and high-grade components and staged as a conventional adenocarcinoma. Here are my references for this talk, and I'd like to thank you for listening.